Morning, everybody. Happy Friday. So we're very excited. We're able to host Journal Club today. And we have a really good Journal Club with lots of great articles that we curated. And I thought we would do a quick Picha Kucha presentation by Zach Tattaron, one of our outstanding fellows in spine. And he's going to talk a little bit about anatomy and then some operative approaches. And then we'll go ahead and after that, start getting into articles. Zach.
Cool. So Paul, it's like 5 minutes. Good morning, everyone. I'm Zach. I'm a neurosurgery resident, completed my residency in Canada. And here's a brief overview. So just a brief overview of cervical spine anatomy in terms of correction of kyphotic deformities, 2 basic approaches, anterior approach, posterior approach, and various pitfalls to navigate with either approach. You've got the vertebral artery running through the transverse foramen in C6 through C2. Actually, in 7.5% of cases, it goes through C7, so you always got to watch for that. And here's just a basic bony anatomy structure, occipital cervical anatomy from posterior approaches, got to watch out for the vert and variations that I'll show later, regular imaging. And then obviously the goal is correction of said cervical deformity. So here's some parameters that we try and get the head over the hips and the knees and just more. Okay, so in terms of the armamentarium of approaches to correcting cervical deformities from the front, you've got your main workhorses are ACDF, larger corpectomy, odontoid screw. Considerations and risks would be postoperative hoarseness, dysphagia, damage to adjacent visceral injuries, esophageal, arterial, tracheal injury, whether or not there's presence of the OPLL, as there is on the picture on the left there, limited occiput to C2 accessibility from the front unless you're going to go transoral. Benefits of this approach, less infection risk, less post-op pain. And then there's the decision whether or not to go with Gardner-Wells tongs or halter traction. The pictures on the right is actually a case Dr. Screen did yesterday, sagittal view of a C3-4. Well, what did it end up being?
We don't know, but they think it's maybe plasmacytoma.
Cool. And then you can see in the CTA, the coronal CTA beneath that, how it splays the vertebral arteries out to the side, which you'd want to take into consideration in your anterior approach. So you've got basic ACDF, larger corpectomy, various cages, bone strut grafts you can use. And then in terms of posterior approach, you've got your workhorses are laminotomy or laminectomy, foraminotomy, laminoplasty, posterior cervical instrumentation and fusion, various things to consider in these approaches. Here's your bread and butter laminoplasty, posterior instrumented fusion, various screws that can be used from O to C7 depending on the goals of the surgery. This is an interesting picture depicting a C5 nerve root palsy and kind of a prediction of the pathophysiology behind post-anterior and posterior decompression. Can both result in C5 nerve root palsies for slightly different reasons. Important to check a CTA to observe any vertebral artery variability that could alter your approach or surgical decision-making. Spinal cord vascular supply, important to choose your sides to avoid right or left recurrent laryngeal nerve. And obviously the sympathetic fibers, good to avoid. So a quick case presentation. This is a case that was done last month here. This is a 58-year-old female, past medical history significant for hypertension, hepatitis C. Past surgical histories were infectious in nature. Patient had a T910 laminectomy at an outside hospital 6 months ago for discitis. She was diagnosed with cervical discitis shortly thereafter, and surgery was scheduled, but then canceled due to COVID-19. She presented via virtual consult with complaints of progressive quadriparesis, inability to eat solid foods. She'd been both wheelchair bound and on a liquid diet for a number of months, and a progressive chin on chest deformity. No focal findings on exam, but she was diffusely weak, enough so that she was inambulatory and relegated to motility on a wheelchair. This is a standing lateral x-ray showing a slight chin on chest deformity and large body habitus, no teeth. And this is a MRI, which shows that she does have some room. So she didn't have frank myelopathy on exam, nor would you expect that from this MRI. About a month later, as part of the workup leading up to surgery, she got a CT scan, which showed a marked progression of her cervical deformity. So in terms of operative considerations for this case, this patient is obviously going to be a difficult intubation. Airway management is going to be an issue. Also, anterior approach is going to make anterior access, or her habitus and chin on chest deformity will make anterior access somewhat difficult. She's also medically compromised. Preoperative PEG tube was discussed, and the goals of surgery were to restore alignment, prevent further neurologic deterioration, and operative plan is 360, 540, just from the front, just from the back. Probably not. This patient ended up having a two-stage procedure. So this is, this is a picture. So she had a 3 to 6 intradiscal cervical osteotomy from the front. And this is the machined bone graft that you can see in the sagittal CT scan, intraoperative fluoroscopy. This was followed by posterior C2 to C7 pedicle, she had a posterior C7 PSO, pedicle subtraction osteotomy, and posterior instrumentation from C2 to T2. Then in terms of the tools in the armamentarium, in terms of osteotomies for cervical deformity correction, there's a good paper from 2013 in JNS by Ames and Schwab that attempts to classify this from 1 to 7, 1 being partial facet joint resection, 7 being complete VCR with everything in between. Here's a picture of the levels or the grades. And of note, this patient also has lumbar and thoracic pathologies, which will be addressed later. Thank you. And we'll go on to the first journal article.
That was great, Zach. I think it illustrates a couple of things. One is that as we continue to learn more about radiographic parameters, we understand now what a huge role the cervical spine has in alignment. So Paul McBride, one of our fellows from Tampa, is going to talk about a great paper and exactly that topic.
Good morning. This is a recent paper out of South Korea. It's titled "The Differential Effect of Cervical Kyphosis Correction Surgery on Global Sagittal Alignment and Health-Related Quality of Life According to Head and Trunk Balance Subtypes." So as we know, the spine is being thought of more and more as one unit instead of 3 separate cervical, thoracic, and lumbar units. And in that vein, we're learning that spinal malalignment is dealt with through compensatory mechanisms in other areas of the spine from the deformity. It does a few things. It maintains an upright posture. It keeps the head over the pelvis, and it helps us achieve a horizontal gaze in the setting of a spinal deformity. This is better understood in the thoracolumbar spine. Compensatory mechanisms like pelvic retroversion, hip extension, knee flexion, cervical hyperlordosis, all these things help us maintain a horizontal gaze. And when you correct a thoracolumbar deformity, these compensatory mechanisms tend to resolve. However, the thoracolumbar response to a cervical kyphotic deformity correction is less well understood. A recent study demonstrated that thoracolumbar alignment changes following cervical reconstructive surgery for kyphosis. And so this paper seeks to sort of extend that a little bit and describe how it affects global sagittal alignment, including the lower extremities, as well as quality of life scores. So this was a retrospective single center study with 23 consecutive patients from 2015 to 2019 with 1-year follow-up. They excluded patients with AS, trauma, tumor, thoracolumbar deformity, as well as lower extremity joint surgery that would prevent any normal compensatory mechanisms in the lower extremity. The patients were divided into 2 groups, a head balanced group and a trunk balanced group. The head balanced group are patients that are using their thoracolumbar spine to bring their head over their pelvis. And these are people that have a hyperlordotic lumbar spine, and it makes their SVA negative. It makes their PILL mismatch also negative because of their high lumbar lordosis. And it brings their thoracic spine backwards such that they have a low T1 slope. The trunk balanced group does not compensate in their thoracolumbar spine, and they have a more normal thoracolumbar alignment. They mostly use their craniocervical junction for compensatory mechanisms and being hyperlordotic there to maintain a horizontal gaze. So these folks have a positive SVA. Their lumbar lordosis and PI is about the same or within normal range. And they have a high T1 slope, and that's because of the high thoracic kyphosis that these people have. Pre-op and post-op EOS measurements, as well as HRQL scores were collected both pre and post-op. So this is a picture of the 2 different subtypes of people that we're talking about. And again, these are both people with cervical kyphosis. However, they compensate in very different ways. So in the head balance group that you can see on the left, these are folks that hyperlordose their lumbar spine. And you can see from the the redundant skin folds and the hyperlordosis that you can see from the sagittal profile. And this pushes their center of gravity line and their C7 plumb line actually behind the sacrum, giving them negative values. And this helps keep a horizontal gaze and helps keep their head above their pelvis. And these people actually compensate pretty fairly well for this. And this is opposed to the trunk balanced group on the right, which is sometimes called the decompensated cervical kyphosis, where you have your center of gravity plumb line, your C2 plumb line well ahead of your sacrum. The C7 plumb line maintains at a generally normal level. They don't hyperlordose their spines to compensate, and their head is well in front of their pelvis. So we have these 2 groups of people, and they took baseline characteristics prior to surgery. You can see that the age before surgery, while it wasn't significant, it was trending towards the trunk balanced folks being older. And I think that's probably because they're less able to hyperlordose their lumbar spines like the younger subset of people are. So that may be a reason for that, although it wasn't significant. The head balanced people had a higher proportion of posterior only surgery. And this may be because of just less of a translation of the head is needed. And so maybe the surgeon thought that they can just get away with it just with a posterior approach, as opposed to the trunk balanced folks that had a more higher proportion of a combined approach for surgery. As far as the radiographic parameters go, I just circled a couple things I thought were interesting. And the trunk balanced people, like we talked about, the craniocervical junction is hyperlordotic, and that's their main compensatory mechanism. The head balanced group is as well. However, it's more so in the trunk balanced group. The SVA of the center of gravity to C7 and C2 to C7, as well as the SVA center of gravity to S1 are all extremely high in the trunk balanced people, like that picture we showed and we talked about. The T1 slope and cervical lordosis mismatch is also much higher in the trunk balanced people. And this is driven mostly by this high T1 slope that you see in the trunk balanced people compared to the head balanced people. Remember, the head balanced people bring their whole thoracic spine backwards. And so that superior end plate of T1 is pretty parallel to the floor. As far as the thoracolumbar and pelvic parameters, this is really what differentiates these people. In the head balanced group, you can see that the thoracic kyphosis is very low and the lumbar lordosis is extremely high. And that's in contrast to the trunk balanced people that have a normal lordosis with a pretty high kyphosis, again, due to that high T1 slope. And then the other important finding is that the lower extremity parameters are not very different in these people. So below the pelvis, they're behaving pretty much the same way. So pre and post-op changes as far as the radiographic parameters go. Again, the cervical hyperlordosis in the trunk balance group pretty significantly decreased. So that compensatory mechanism that they were using to maintain a horizontal gaze, once you fix the C-spine, tends to normalize more so in the trunk balance group than the head balance group. All the cervical parameters that you'd expect, the C2 to 7 lordosis, center of gravity to C7 and C2 to C7 improved pretty markedly in both groups, although as would be expected more in the trunk balance group because they were worse off to begin with. The plumb lines do kind of some funny things, and it's easier to show that in a picture, so I'll skip that section. The thoracic kyphosis changes in different directions for each people. The head balance group, thoracic kyphosis increases, whereas the trunk balance group, it actually decreases. And that was a finding that was different from a similar paper that they cite a couple times where it had no change. So that's an interesting finding we'll kind of talk about in the discussion. And then as expected, the lordosis and the PILL mismatch changes significantly in the head balance group to revert to a more normal situation because they no longer need that compensatory mechanism. But in the trunk balance group, there was no significant change. And again, no significant changes in the lower extremity parameters. And so this is a representative case of a trunk balanced patient pre and post-op. You can see how the plumb lines, the center of gravity, C2 and C7, are all very far apart, and then they normalize but stay in the same order after surgery, this with the center of gravity being the furthest ahead of the sacrum. This is in contrast to the head balance patients where they actually change order, and they hypothesize that this is because they're changing their thoracolumbar orientation, and this is actually pushing the top of the thoracic spine forward, and that brings that C7 plumb line forward in front of the sacrum while bringing the center of gravity backwards. This was the quality of life table. That the significant finding here is that while all patients improved from a neck pain standpoint, only the head balance patients improved from a low back pain standpoint. And this makes sense because they are no longer using their hyperlordotic compensatory mechanisms and straining their low back to bring their head above their pelvis. So that normalizes and their low back pain goes away, whereas the trunk balanced patients weren't doing that to begin with. So you wouldn't expect that their low back pain would improve. So some discussion points. So there's two general patterns of global spinal alignment and cervical kyphosis that behave pretty differently. Neither of these groups use their lower extremities to compensate. The head balanced or the compensated group uses thoracolumbar compensation, and this resolves after surgery. The mismatch normalizes and their low back pain improves. The trunk balanced patients, which are the decompensated group, their craniocervical hyperlordosis improves. They have no change in their low back pain or their lumbosacral parameters, but their thoracic parameters do change. And the T1 slope becomes more parallel with the floor, and this was different than the prior study. And they say that because of this, they are suggesting that a selective cervical correction for the head balance subtype would be warranted, and a cervicothoracic correction for the trunk balance subtype would be warranted. And so I wish they kind of delved into this a little further. I don't know what they meant by selective cervical. I think both groups deserve a fusion from the cervical spine to the thoracic spine. I don't know if they meant the cervicothoracic correction should go lower to like T6, where the other group should go to T2. They didn't elaborate on that. And then some limitations of the study. It's a small N, only 23 patients, just 1 year follow-up, 2 years or more would be nice. And then they say that there was a heterogeneity of surgical indications, both iatrogenic and also de novo cervical kyphosis were included, but I think that's more of a strength than a weakness. So that's it.
Great, thanks, Paul. I think this paper is very important because it kind of, again, it looks at, you know, if you do anything in the lumbar spine or thoracic spine, it affects the neck. And if you do anything in the neck, it affects the thoracic and lumbar spine. So thank you so much. We're going to go ahead and move forward with our next article. So Dr. Price is going to continue on this theme of looking at deformity. And actually, I think, Rick, your article's on how deformity surgery has impacts on the cervical spine.
Yeah.
Which again, I mean, a lot of us do a lot of deformity surgery, and we end up seeing our patients having more neck problems after you do their scoliosis or deformity correction. So Rick's going to talk about an important paper.
Lee.
Great.
There we go. Hey, I'm Rick Price. I'm one of the spine fellows here. This is a really good segue from what Paul was talking about. We know that when we do adult spinal deformity, that it can cause a cervical deformity, but this study here particularly looks at the timing of cervical deformity after spinal deformity surgery. This is a timing of conversion to cervical malalignment, proximal junctional kyphosis, following surgical correction of adult spinal deformity, 3-year radiographic analysis. So from the International Spine Study Group, Peter Kyphosis is the first author. It was published in the JNS Spine back in March of this year. And the objective of this paper is to assess the conversion rate from baseline cervical alignment to post-op cervical deformity and the corresponding PGK rates and patients undergoing thoracolumbar spinal deformity correction. So as we know, adult spinal deformity is highly invasive and has many risks, including new onset cervical deformity. And there's a rising incidence in cervical deformity that we're becoming aware of. I think this is probably likely that we have better parameters, we have better measurements and better classification systems that I'll talk about in a second that allow us to recognize when cervical deformity is occurring. And then as Dr. Skinner was just mentioning, is that ASD surgery can cause reciprocal changes in neighboring spine regions as quote unquote chain of correlation. That, you do something in the thoracolumbar spine, you'll also have some sort of reciprocal compensatory change in the cervical spine. And PGK incidence in spinal deformity surgery is widely quoted or widely varied, but it's been reported mostly between 11 to 41%, with some studies going up to 50 to 60%. And little is known about the timing in which these reciprocal changes occur after the index thoracolumbar correction. So method of this paper is a retrospective analysis from the ISGG study group, which is 12 participating institutions. Patients that were included in this study were patients that underwent spinal deformity surgery with baseline through 3 years of follow-up. This included 266 patients. The inclusion criteria for this database is pretty simple. It's patients greater than 18 years of age with baseline documented adult spinal deformity. And then with these patients that they selected, they used SpineView software to assess all the spinal pelvic parameters. They used the AIMS criteria, which is T1 slope cervical lordosis mismatch, cervical SVA, and cervical kyphosis, and also they assessed PGK, which is how they defined it was the angle formed between the inferior end plate of the UIV and the superior end plate of the UIV +2. And about several years ago, Dr. Ames and the ISSG published the AIMS cervical deformity classification. I'm not going to go into this into detail, but it has a deformity descriptor as well as some modifiers. The primary descriptors are sagittal deformity, apex in the cervical spine, primary sagittal deformity, apex in the cervical thoracic junction, sagittal deformity in the thoracic spine, coronal deformity, and then cervical vertebral junctional deformity. And the modifiers are on the right, which really don't have any implication in this paper, so I won't go over them. Right. So table 1, they did simple radiographic baseline assessment compared to a 3-year alignment. And all patients were cervically aligned at baseline with average cervical SVA of 28.2 and then cervical lordosis about 10.6. The average number of levels fused in this group was about 11.3 levels, typically a T10 of the pelvis. And at 3 years here, spinal pelvic alignment significantly improved. So you see here, pelvic emphasis lumbar lordosis mismatch, pelvic tilt, and then SVA are all significantly improved at 3 years. Interestingly, and this goes along with this paper, is that the SVA, the cervical SVA, significantly increases over this 3 years, showing that there is a significant increase in deformity. And then there is no significant increase in cervical lordosis at the 3-year mark of the study. So what made this paper so interesting is they really dove into the timing of the conversion to the cervical deformity. And this is a Kaplan-Meier plot that at the 6-week post-op period, 14.3% met criteria for having cervical deformity. And what they classified this as cervical SVA greater than 40 degrees or thoracic slope cervical lordosis mismatch greater than 20 degrees. And then as you go through time, through the 3-year follow-up, you have a steady increase, this is inverse of the Kaplan-Meier curve, of patients converting to cervical deformity. And this is just at the 3-year mark. It's unclear how this plays out long-term over 5 or 10 years. I imagine it would probably be a similar progression, linear progression. So they did a deeper dive and did logistic regression analysis on predictors of the patients that could convert to cervical deformity. And they broke it up to early conversion, which is less than 1 year after the index surgery, versus late conversion between 1 to 3 years. And the predictors that came out, and these were all for the late conversion, 1 to 3 years, is patients that had a high cervical lordosis, the index surgery, high C2 to T3 Cobb angle, or a more superior apex of lumbar lordosis. As I said, these were all late predictors. They were statistically significant. However, the odds ratio was right around 1 or 0.35, which I think is rather significant. And then they had rate of predictors for those patients that did not convert to, for who converted versus did not converting. And the patients that had a high mismatch had a higher likelihood of converting, a lower L1, S1 lordosis, which means, the vertebral body at the apex is lower. And then also a lower T4 to 12 kyphosis, thoracic kyphosis. Then they looked closer at patients that developed PJK and their rate of cervical deformity. Their overall rate of PJK in the study was about 15%. But then if you look at patients that had PJK as cervical deformity, it was about 52%, which is pretty correlative. So I'm not going to go into this, this table too great. But what they did is they looked at when these patients converted to cervical deformity, it would be within 6 weeks, 1 year, 2 years. This was their revision rates. That patients that had early cervical deformity, they had about 10% chance of revision. As if late, they had about 50%. And what they were showing is that patient that had these concurrent PJK rates, that as the PJK rate increased, their likelihood of needing a revision increased as well. And then their mode, based off the timing of the cervical deformity, there was patients that were at early conversion most likely had a T1 to 3 versus, as an intermediate was T10 to 12, late T10 to 12, but then the long term would be like the upper instrument vertebral body would be T4 to 6. And then as I was saying before about the revision rates, they looked at the most likely level of the UIV based off the timing of the cervical deformity conversion. And at less than 6 weeks, the early patients was T3 to 4, which I think makes sense that if you completely fuse somebody from T3 to the pelvis, there is going to be some sort of compensatory mechanism in the neck that could cause deformity. But then at all time points after that, 6 weeks to 3 years, the most likely UIV was T10, like a T10 to pelvis. And I think that what they're trying to say is that as people get PJK at the T10 level, their likelihood of developing cervical deformity and then needing surgical correction increases. So I went over a couple case examples. This first patient underwent a T3 to pelvis, and this was a late converter. And this patient had increased thoracic slope, cervical lordosis, and C2 to T3 angle. And then, so these were predictors of a late conversion. And this is an example of a T10 to pelvis, which is interestingly was an early converter, but because these typically convert late to cervical deformity. But this patient had a lumbar lordosis apex at L3, and they're saying higher lumbar lordosis apex is a risk factor for early conversion. So just discuss this paper a little bit. This is the first study to examine the timing development of cervical deformity after index surgery of adult spinal deformity. And then, as we were saying earlier, this shows that regional correction of spinal alignment can affect the cervical spine in the postoperative period. And then these reciprocal changes that occur are what's responsible for this cervical deformity. And what they were showing in this paper is that we may be treating two different problems based on early or late development, where the early cervical deformity may just be compensatory from changing the global alignment of the spine, whereas these late developers are more likely related to PJK development. So one of the take-home points of this paper is, consider global alignment, not just, the pelvic parameters when performing like a T10 to the pelvis, and then potentially modifying your plans based off of some of these risk factors. To conclude, there's 26.8% of the patients converted to cervical deformity in a 3-year period after adult spinal deformity surgery. More patients converted in the immediate post-op period, about 14% of the total 27%. And latest conversion after 1 year was associated with that PJK. And the predictors of cervical deformity conversion included higher baseline mismatch, lower thoracic kyphosis, and lumbar lordosis. So I had a couple critiques and limitations of the paper I wanted to point out. This was a multi-center, multi-surgeon study. It was really hard to standardize the approach among all these surgeons, and it was unclear what type of surgeries were performed. They just described the levels, but then didn't talk about any of the correction that was obtained of was the patient truly balanced after surgery or not. And then they didn't examine whether cervical deformity was associated with revision surgery or further patient issues. This was just a paper that described the radiographic findings. So it's unclear that if this cervical lordosis actually mattered in these patients. And this was actually a rather difficult paper to get through. There was just so many parameters that was saturated with both cervical and lumbar measurement parameters. It's rather difficult to follow. But they did not examine any of the outcomes of these patients. Do the numbers really matter? You don't treat the image, you treat the patient. I think in this case, you don't treat the numbers, you treat how the patient's doing. They're mismatched, but they're doing great. Does it really matter? That's all I got. Any questions?
That was great, Rick. I think this is a really important topic, and I think we're going to get more and more data. And people, as you said, I think you have to look at the entire spine. You can't just focus on the thoracic or lumbar spine. I think global alignment is really an important concept, and I think Professor Dubuisset always says it's you have to treat the patient, not the parameters. So Rick, great job.
Rod, if I can just make a comment.
Yeah.
Both these papers, the one thing that stands out is the premise that the brain will sacrifice alignment to maintain balance. So the brain's going to do whatever it wants in whatever region of the spine that you still have mobile. And we get into the philosophies of lumpers versus splitters here. We can see that this paper, as Rick pointed out, all the parameters, you're starting to split and slice and dice, and you really can't make any conclusions. But what happens in this, and particularly this paper points it out, that those late developers, the brain is not able to easily compensate. So that's why you're developing the PJK, and then you start to get the other compensatory mechanisms. So a lot of this, if you just think about it globally, as you mentioned, is pretty intuitive.
No, that's a great point, Izzy. And also, I think Dr. Elias is going to show a case here that Dr. Hart recently did and then discuss another important paper. I think we get so focused on the areas that we're working on is that you don't take in all these factors that you just brought up, Izzy. So I think that's an excellent point. So Dr. Elias is going to present a very interesting case that Dr. Hart recently did and then a nice paper.
So good morning, my name is Elias. I'm one of the spine fellows here at Swedish. I will first present the case I did with Dr. Hart. So I have this 52-year-old male. He presented with cervical pain and he had difficulty holding his neck straight. This was associated also with gait imbalance and disturbance. Mainly he had left hand weakness and sensation of pins and needles in both feet. He was diabetic, hypertensive, dyslipidemic, and on exam, there was mild weakness over his left intrinsics. So those are his scoliosis x-rays. And if you can notice here, you can notice some coronal imbalance over the cervicothoracic area and the loss of lordosis over his cervical area. Those are the plain X-ray, cervical X-ray, flexion extension. And as you can see here, this is the extension X-ray. Those are the CT scan of the patient. There is a marked shift over the left side. And there is coronal imbalance over the cervical and the cervicothoracic junction. This is his pre-op MRI, multiple disc disease over the cervicothoracic area, mainly the lower cervical area. So the plan was to take him to the OR. We did two-stage surgery in a single setting. The first one was the posterior approach from C2 to T7, and it was complemented with anterior approach from C4 to C7. So this is a clip of the surgery. On the left side, this is the second stage of the surgery with allografts, and on the right side, this is the first stage of the surgery. We used quad rods over here. And again, you can note now the correction of the cervical lordosis and the correction of the coronal imbalance. So this is an intra-op picture of the surgery. This is the caudal end. This is this is the rostral end, and this is the caudal end. Here we did the C3 to C6 laminectomy. This is the dura here, and those are the ponte osteotomies for the deformity correction. And here you can see the quad rods that were used. This is the post-op X-ray of the patient. There is a good cervical lordosis compared to the pre-op X-ray. And this is a comparative CT pre-op compared to post-op. So now I will go to the paper.
I think that patient had pretty significant myelopathy as well.
Yeah, that's true.
With cord signal change.
Yeah. So I will present this paper. It was published in Journal of Neurosurgery Spine in 2015. It's about, it's entitled How the Neck Affects the Back, Changes in Regional Cervical Sagittal Alignment and Correlation to Quality of health improvement in adult thoracolumbar deformities. So objective of this study was to examine the relationship between cervical and thoracolumbar lumbar alignment parameter with the quality of life among patients with the thoracolumbar deformities. It was conducted throughout 11 sites, taking only adult thoracolumbar spine deformity patients with at least one of spinal deformity measurements, such as Cobb angle, SVA more than 5, PT more than 25, or thoracic kyphosis more than 60. Patients were then categorized later on for analysis between SVA more than 5 and less than 5 centimeters. Okay. And so data collection included patient's age, gender, BMI, the comorbidity index, numeric scale, rating scale, ODI, SR36, and SRS22. And follow-up was done at 2 years. They took the following radiographic assessment, such as C27 SVA, C27 lordosis, T1 slope minus cervical lordosis, thoracic kyphosis, lumbar lordosis, PT, and PILL mismatch. So regarding the results, total of patients included was around 318 patients. Mean age was around 60. And when they subcategorized the patient between SVA more than 5 and less than 5, they found that patients who had operation and with SVA more than 5 had a higher mean age, higher BMI, and higher comorbidity index. When they compared the operative versus non-operative patients, the operative one had higher NRS and a lower SRS, which reflects a lower quality of life, and a higher ODI. And when this was subcategorized also between the operative patients only, the ones who had SVA more than 5 had same or similar outcome, such as higher NRS, higher ODI, and lower SRS score. So when they took into consideration the cervical parameters, like C27 lordosis and C27 SVA, it also reflected on a correlation between the global alignment, or like C7 SVA, and the cervical parameters. The same for the thoracolumbar alignment, such as PT and PILL. And all those values were found significant. Again, when they took all the patients without certification, they found that the cervical parameters by themselves, such as the C2, C7, SVA, and the cervical lordosis, was correlated with ODI and SRS. Then they assessed the correlation between the changes over 2 years, and they found positive correlation or significant correlation between the C27 SVA change and the cervical lordosis change and the other thoracolumbar parameters. So they also found that when we have a lower C27, when the C27 change decreases, the ODI, for example, will also decrease over a 2 years period. So for the discussion points, they found that cervical lordosis, C27 SVA, were correlated with measurement for the disability among patients with adult thoracolumbar scoliosis, and patients with higher SVA or SVA more than 5 had a larger baseline cervical lordosis, T1 slope, C2 SVA, and lower quality of life than those who had SVA less than 5 centimeters. They mentioned that fewer studies correlated cervical sagittal alignment with validated quality of life. 2 authors, one of them was Teng et al., had a paper with 113 patients who had PCDF, found a positive cervical sagittal alignment was a detrimental effect on SF36 and the NDI, or neck disability index. Another author had an RCT of a lordotic patient who had ACDF. RCT was for 122 patients, and he showed that patient whose cervical sagittal alignment was maintained or improved reflected a good outcome on SF36 and the NDI outcomes. So finally, they concluded that a decrease in C27 SVA was correlated with a better quality of life at 2 years, even with patients with the initial SVA of more than 5. And again, the C2 SVA improvement was correlated with improvement in ODI. So limitation of the study was mainly there are no neck-specific questionnaire that was used in this paper, such as the neck disability index. And other limitations is that this paper was done retrospectively. Strength is that it was 11 sites were picked for patient selection. They used multiple quality of life standardized measurements, and the follow-up was 2 years. So in conclusion, they found that thoracolumbar deformity correction had a direct, maybe small, but beneficial effect on health measurement outcomes for improved cervical sagittal alignment and reduced cervical hyperlordosis for maintenance of horizontal gaze. Thank you.
Great, thanks, Elias.
Thanks.
So I think that particular patient, it was interesting because, again, I think what I wanted to illustrate is that things like myelopathy sometimes don't end up in their overall, when you're doing these outcome measurements, and they get kind of overlooked, but that patient had clear neurologic progression, and that was the reason why the deformity surgery was done. And sometimes, that gets lost in the health-related quality outcome measures, which include pain, narcotic use, and a bunch of other things. So we're going to continue. We're pressed for time. Dr. Fayumi, one of our fellows, is going to continue with this theme, and he's going to show an excellent case that they recently did. And again, this is a case I think we did last week.
This is actually an older case that I.
Oh, okay.
Yeah.
And also to talk about just alignment and how we take those measurements. Puriya.
All right. Thank you, Dr. Oscar. My name is Puriya Gayomi, one of the fellows here. The case that I'm presenting actually was done a few years back, so with longer follow-up. I don't know why I keep losing the screen here. Lee, can you help me here, please? Yep.
There we go.
Connected. Okay. All right. Her patient is a 62-year-old female. She had a history of C3-4A CDF that had ongoing neck pain, bilateral hand numbness, and that was progressively worsening over the years. She progressively, her ambulation. Sorry, it's okay. Thank you. At this point, she has to use a cane to ambulate, and she feels that her head is progressively tilting forward and to the right. She's had a history of multiple lumbar surgeries, including fusion on multiple levels and eventually removal of hardware. She doesn't have any bowel or bladder issues. Her comorbidity is that she has COPD. Sorry about this. I don't know why it keeps. Thank you. She has COPD, she has diastolic heart failure, and she used to be a former smoker. On her physical examination, as you can see, she has bilateral weakness in upper and lower extremities, 4 out of 5. She is hyperreflexic. She has positive Hoffmans and IBRs. So she has basically this progressive myelopathy that has been ongoing for years. And this kind of brings together everything that all the other fellows were talking about, this global malalignment combined with a cervical malalignment. As you can see, she has this coronal deformity that's about 20 degrees of scoliosis. She has this both clinically and radiographically, this torticollis that is very notable on clinical exam as well. And she has listhesis at C4-5. And I put that the full spine x-ray on the right-hand side. Unfortunately, I wasn't able to do any measurements with this kind of combined image, but clearly increased SVA. She has kyphotic deformity at the thoracolumbar junction that has progressively been worsening throughout the years. So we had a lengthy discussion with her regarding the treatment options and whether to address the neck versus her lower back first. Given that she has this progressive myelopathy, the decision was to address her neck issues first, but she does understand that for correction of her thoracolumbar, that she will probably, the construct will end at upper thoracic versus mid-thoracic area, and there will be a few mobile segment between the cervical and thoracic and thoracolumbar fusion, and that could be a problem down the line. These are her MRIs that she has. As you can see, she has multiple level spondylosis and stenosis in her cervical spine. The loss of lordosis is evident even with her supine on an MRI machine. So she ended up having a two-stage procedure, ACDF and osteotomies of C4, 5, 6, and 6, 7 using structural allografts, and same day posterior procedure, C2 to T2 with laminectomies. And these are her post-op images. And these are her post-operative CT. As you can see, she her both coronal and sagittal alignment improved greatly compared to her preoperative images. All right, if no questions, I'm going to move on. All right, as for the paper, this is a narrative review paper that kind of brings everything together that everyone else pretty much talked about, and it goes through multiple different studies on this topic in cervical radiographical alignment. As others mentioned, the indication for correctional surgery of cervical malalignment is not as clearly well defined as it is with the thoracolumbar spine. Classification is lacking, and there's some recent evidence that shows that aside from progressive stenosis, actually the deformity itself can be a cause of myelopathy. This has been shown that with sagittal malalignment, there's increase with cord tension, flattening, and increase in intramedullary pressure. There's been shown a correlation between degree of kyphosis and cord flattening with decreased vascularity, and kyphosis more than 51 degrees has been shown to lead to increased intramedullary pressure. So the point of this, the aim of this review article was to go through basically cervical alignment parameters, methods of quantifying them on a radiograph, and define normal values, and how these type of parameters, mostly sagittal parameters, would lead with cervical deformity and myelopathy would affect patients' quality of life. So in terms of alignment, again, everyone basically went through these pretty extensively, but just briefly for measuring cervical lordosis, there are two main methods to do that. One is a Cobb angle, which basically is a line parallel to the C2 inferior end plate and C7 inferior end plate, two perpendicular lines to them, and you measure the angle between the two. There's also the Harrison tangent method, where you draw parallel lines to the posterior surfaces of all the vertebral bodies on the cervical spine, and you add up all the segmental angles. In terms of SVA of the cervical spine, we all know about the C2 and C7 plumb lines, and as it comes to the global sagittal alignment. But for cervical spine specifically, you can basically do an C2 to C7 SVA, which is a line from the center of C2, and then you measure that distance from the posterior superior aspect of C7 to that line, and that is your cervical SVA. And I know Paul already talked about the center of angle SVA as well, so I'm not really going to get into that. In terms of measurement of horizontal gaze, they talked about the chin-brow vertical angle, which is a line between, you draw between the chin to brow, and the distance and the angle between that line and the vertical line. In terms of sagittal alignment and sagittal parameters, these are very well defined, and everyone's familiar with them in the lumbar spine, including the pelvic incidence, pelvic tilt, and sacral slope. Similar type of parameters have been defined in the cervical spine, and these include the thoracic inlet angle, T1 slope, and neck tilt. So thoracic inlet angle, you draw a line from the manubrium to the middle of the superior end plate of T1, and another line perpendicular to the upper end plate of T1, and that would be your thoracic inlet angle. Your T1 slope is basically similar to your sacral slope, is a line over the superior end plate of T1, and the angle between that and the horizontal line. And there's similar type of correlation between these measurements. You have that in cervical spine as well, whereas thoracic inlet angle equals T1 slope plus neck tilt. And this kind of goes through the correlation between the sagittal alignment and the cervical spine. As you can see, this chain of correlation between the pelvic incidence. As your pelvic incidence goes up, you require more lumbar lordosis to maintain that. And as that goes up, you basically go into hyperkyphosis to maintain your alignment, and your cervical lordosis increases as well as to compensate for that change. Normal cervical alignments, I kind of go through it. I think the things that really matter here is that normal cervical lordosis is about 40 degrees on average. From occiput to C1 actually is the only kyphotic segment, about 2 degrees or so. Most of your cervical lordosis come from C1 to C2, about 32 degrees, and then to a lesser degrees at the other levels below. And then they talked about cervical alignment, deformity, and quality of life measures. They had a few studies, as some of them that were discussed today, report on relationship of cervical parameters and quality of life. Most of these studies focus on kyphosis, and it's been clearly shown that increased kyphosis lead to increased neck pain. There's been multiple studies that shows that in terms of measurement of lordosis, only segmental alignment actually correlates with clinical outcomes and not the overall cervical lordosis, which I thought was surprising. And also CBVA, in terms of measurement of horizontal gaze, correction of that can lead to positive postoperative outcomes. Once again, SVA, or the global SVA, has been extensively studied, and we all know about the major studies as it comes to relates to thoracolumbar deformity. Not the same has been done for cervical deformity, aside from very few studies. One study showed that increase in C2 SVA leads to poor quality of life measures. C2 SVA more than 40 millimeters correlated with worse NDI and significant correlation between C2 to C7 SVA and T1 slope, as it shows in this table. As your lordosis, as your SVA increases, C2 C7 SVA increases, your T1 slope increases to basically be able to maintain that horizontal gaze, which makes sense. It's very similar to the lumbar spine. There was one study that showed that, done by Kim, that investigated the preoperative T1 slope and its correlation with postoperative kyphosis after laminoplasty, and they found that patients that had a higher T1 slope preoperatively were at a much higher risk of developing postoperative post-laminoplasty kyphosis at 2 years follow-up. In terms of correlation between cervical alignment and myelopathy, as I mentioned, there's been some studies that showed that deformity itself contributes significantly to development of myelopathy in these patients. And this has to do with, as you become more kyphotic, your cord basically pushes against the vertebral bodies and induces anterior cord pathology, cord tethering, as you have the dentate ligaments that holds it in place. It leads to increased longitudinal tension, especially anteriorly on the cord. And with increase in intramedullary pressure, you can actually lead to neuronal to demyelination and progression of myelopathy. In conclusion, this was a narrative review that kind of brought together everything that we talked about today. Cervical spine deformity correction, we should consider it as a part of the global approach to when we look at the spine deformity. T1 slope is a very important parameter out of all the other sagittal parameters in the cervical spine. It's been studied the most, and it's been shown to should be considered for deformity correction in cervical spine. And also it's been shown to be important in development of post-laminectomy kyphosis. In patients with global sagittal imbalance, lordosis of the cervical spine increases as a compensatory mechanism, and sagittal malalignment is an important factor in development of myelopathy. Thank you.
That was great, Poria. I think what's interesting is that, when you look at, actually, that was that case that you showed, even though you guys only focused on the cervical thoracic junction, you could see that patient had a significant deformity. And I think they're 3 years post, and you guys haven't done anything to the thoracolumbar spine, right? So.
Not yet, no.
Yeah. So, I mean, I think, all these papers, and part of the reason, and you're looking at this as well in your research project, is you can see, a lot of these patients have, just in terms of their overall, like this patient, significant number of medical problems. And in addition to having both a cervical and thoracic and lumbar problem. And, you guys did an excellent job correcting a cervical thoracic deformity. And again, in terms of, what parameters to use, what measurements do we use, this is all language and terminology, especially with payers. What is the outcome? What's their neurologic function? All these things. I think as we get more data, hopefully we can talk the same language and start publishing on our outcomes because I think the outcomes on these patients are, they're life-changing. But again, you have to look at the entire spine. So I know we don't have much time. Jack and Izzy, I don't know if you guys have any final comments, but this was a very interesting topic because I think the literature is still accumulating and we're learning more and more as we continue to get long-term follow-up.
Rod, the only thing I'll add is I'm glad we're finally paying attention to all of this. Great job, fellows. Have a great weekend, everybody.
Great. Thanks, guys.
Take care.
Thank you, Rod. Take care.
Have a good one.